everybody. Thank you so much for being here today. Thank you for that introduction, Geneva. I'm excited to talk to you a little bit more about melatonin and how you can use it in your clinical practice, specifically for women's health. Let's start out by talking about melatonin's role as the master regulator for all physiological systems and dive into some of its unique properties. So, since ancient times, human existence has been shaped by the rhythms of light and dark, days and months, season and years, based on the cycles of the Earth's rotation around the sun. Chronobiology is a newer branch of biology that's related to cyclic physiological rhythms. In this branch of science, chronobiology, you can think of melatonin as the master conductor of a symphony, or the mother hormone of all chronobiology. And this gives credence to the importance of melatonin's association with darkness. And when I say darkness, I mean true darkness, something that most modern humans do not experience in their life. Even if one has blackout curtains, they are still being exposed to light pollution from devices inside their home while they're sleeping. Even when your eyes are closed and sleeping, the retina is able to detect light from a smoke alarm or a light switch or an air filter or an air conditioner. And that light is a signal to the suprachiasmatic nucleus, which then signals the pineal gland to reduce or stop its release of melatonin because light suppresses melatonin. When this finely tuned rhythm is consistently disrupted by messages of light at night or darkness during the day or irregular sleep and wake patterns or medications, alcohol, stress, trauma, a snoring partner, pets, children, the list goes on, anything that will interrupt sleep, there's a physiological toll, and it can manifest in chronic diseases and imbalances impacting the systems that revolve around that light and dark circadian rhythm. Thankfully, there's a growing body of evidence that shows that melatonin supplementation can affect positive change in many of those imbalances. So here's a depiction of that symphony conducted by melatonin and the suprachiasmatic nucleus. It's a simplified image of a 24-hour circadian cycle where you can see when certain physiological functions happen at certain times due to the interplay of melatonin and darkness and cortisol and light. So in the morning, with the rise of ACTH at the end of the sleep period, cortisol, epinephrine, and body temperature increase to help us get out of bed. And this is also when the sex hormones testosterone and progesterone are at their highest. As the day progresses, blood pressure and heart rate will increase. And when body temperature reaches its peak around 6 p.m., insulin, cholesterol, and triglycerides are also at their peak. And then comes the evening ascent of melatonin, or what we call the dim light melatonin onset, the DLMO, which signals a decrease in body temperature. Pineal released melatonin is highest at night in darkness, sometime between 1 and 3 a.m. And this is also when many of the oxidative stress enzymes are at their highest and subject to circadian influence. So note that this crucial time of melatonin peak is also when most of that immune modulation is going to take place, as well as TSH and growth hormone production. So all of these systems, nervous, immune, reproductive, metabolic, cardiovascular, and endocrine, are crucially dependent upon this finely tuned symphony of light and dark, sleep and alertness based on a consistent 24-hour rhythm. And thus they're greatly impacted by chronic irregularity of light and dark and sleep. So here's another depiction of those daily rhythms. We're looking at the daytime here in white and the nighttime in this gray. And you see that plasma melatonin here, you see its peak in the middle of the night, in the middle of the sleep period, at which point cortisol is at its lowest and core body temperature is also at its lowest because melatonin signals a decrease in body temperature. And then in the morning, as that body temperature increases and cortisol increases and hits its peak, 30 minutes after we wake up with the cortisol awakening response, that's when we're going to see melatonin on the downswing. Now you can see that when cortisol is at its highest, melatonin is not at its lowest. It's on its way down. So this is something that we're going to talk about a little bit more later, but I just want you to get a good sense for what's happening at night with this interplay of hormones, and then during the day with the interplay of hormones and how they suppress each other. Cortisol suppresses melatonin, melatonin suppresses cortisol, melatonin decreases temperature, cortisol increases temperature. This is what most of us are going to think about when we think of melatonin, that circadian signaling that's associated with light and dark in a 24-hour period. The messages of light and inhibition and darkness and stimulation are going to travel via the suprachiasmatic nucleus as a result of the retina. And it's going to go to the superior cervical ganglia and then back up to the pineal gland. But now we're realizing that this image of pineal release of melatonin only scratches the surface of the impact that melatonin has on the entirety of the human body, and only represents about 5% of total body production of melatonin. And here's the bigger picture, a representation of melatonin's effect on the entirety of the human body due to the ubiquitous location of melatonin receptors in most organs, muscles, reproductive organs, and bodily fluids, including amniotic, breast milk, cerebrospinal fluid, feces, synovial fluid, saliva, and urine. Because melatonin is an amphiphilic molecule, it has both polar and non-polar regions. It enables it to cross all morphophysiological barriers, such as the blood-brain barrier, the placenta, and all cells of the body, which contributes to its four main functions as a hormone, a mitochondrial regulator, a potent antioxidant. One molecule of melatonin can scavenge up to 10 reactive oxygen species versus vitamin C, which scavenges 1 to 2, and well as anti-inflammatory. While melatonin is ubiquitously located, there are only 3 cells that produce it. So this might be a little bit of a surprise because until now we really thought it was just the pineal gland. But recent research is suggesting that there's production coming from other places. So we know about the pineal gland and its production of melatonin in the middle of the night in dark. So where does that other 95% come from? Well, the enterochromaffin cells of the gut lining produce upwards of 400 times the amount that's produced in the pineal sites. But this GI production is not systemic. Its effects are more local or paracrine, are called non-releasable, versus the pineal gland's melatonin, which is releasable and systemic. And the mitochondria also produce melatonin wherever there is intracellular need. So like the gut, the mitochondrial melatonin is non-releasable. It's a paracrine and local form versus a systemic form. Mitochondrial levels are much higher in melatonin because mitochondria is much higher in melatonin than blood because of the antioxidant needs of the mitochondria, which also houses the electron transport chain, which is a potent producer of free radicals or pro-oxidants. So melatonin reduces that oxidation and scavenges free radicals, serving in a redox role, meaning it reduces the reactive oxygen species, and it supports healthy levels of antioxidants like superoxide dismutase. Melatonin concentrations vary across the lifespan and are much hardier when we're young and decrease consistently with age. So you can see that infants younger than 3 months secrete very little melatonin, but melatonin increases and becomes circadian in older infants and reaches a peak nocturnal concentration in early childhood, and then it starts to decrease. And right about that time of that decrease is when puberty sets in. And after that, melatonin levels are going to decline gradually about 10 to 15% per decade. And older people produce comparatively little melatonin. Many diseases that we associate with aging, such as neurodegenerative disease, heart disease, metabolic disorders, osteoporosis, and cancer, are associated with abnormal mitochondrial dynamics, meaning that cells are less protected from oxidative stress. As well, neurological diseases such as Alzheimer's, Parkinson's, ALS, Huntington's, epilepsy, schizophrenia, MS, neuropathic pain, muscular dystrophy, and diabetes are also associated with that decline in melatonin. Supplemental melatonin has been shown to offset this decline, and it's also shown an ability to contribute to physiological regeneration over time. So just keep that in mind, that as our melatonin levels decrease, we become more and more susceptible to the diseases of aging and neurological diseases. So the research is showing us more and more how essential melatonin is to all human functioning. This image is from a newer review article that's written by some of our esteemed functional medicine colleagues, who posit that as vitamin D is the essential hormone and nutrient of daytime, melatonin is the essential hormone and nutrient of darkness. So as one can experience the vitamin D deficiency if there's not enough light exposure to the sun, one can experience insufficient melatonin due to insufficient darkness exposure at night. Both are going to have similar physiologic roles. So here's what they both do. They both have hormone actions and antioxidant and anti-inflammatory properties. They're both immune modulators, mitochondrial regulators, and have system-wide effects. Chemically, melatonin comes from the serotonin pathway. Once serotonin or 5-HT is formed from tryptophan and 5-HTP, in darkness, the N-acetyltransferase attaches an acetyl group to the indole portion of serotonin to form N-acetylserotonin. And then the HIOMT enzyme catalyzes a final reaction by converting acetylserotonin into melatonin. So here's another depiction here on the left from our neurotransmitter pathway chart. And you can see very clearly tryptophan converts into 5-HTP, converts into serotonin, into acetylserotonin, and finally into melatonin. So if one's going to be low in serotonin or running lower in serotonin, they're very likely also going to be running lower in melatonin. So let's take a closer look at melatonin's role in the mitochondria. Remember that the mitochondria is located in every cell of the human body and is the preferential site of synthesis of both ATP and reactive oxygen species, due to the electron transport chain also being located in the mitochondria. So the mitochondria both produces reactive oxygen species and produces melatonin capable of neutralizing those reactive oxygen species. So here's where it gets really interesting. Mitochondria can both take up pineal-derived melatonin from circulation, that 5% from the pineal gland, and it has the ability to produce its own melatonin for intracellular and paracrine uses. So in this sense, mitochondria are dependent upon the antioxidant effects of its own production of melatonin to counterbalance its own production of reactive oxygen species. So this larger pink square that you see here is representing a cell, and the smaller organelle, the smaller orange rectangle that you see is a close-up of the mitochondria. So you can see the production of melatonin via the serotonin pathway in an autocrine fashion for the cell's own antioxidant use, and in a paracrine fashion where it's released into the cytosol, where it can be received by a neighboring cell and or absorbed back into the cell that produced it. The ATP that's produced by the mitochondria cannot be stored. It's a perpetual generation process by the cell. So if there's any interference with that process because of reactive oxygen species, we're not going to be producing the ATP that we need. So there are thousands of mitochondria in each cell, making it important that they can function properly to form this redox process. The more melatonin we have, the more antioxidant potential we have, the less melatonin, the less antioxidant potential. So this gives a picture of the macro effects of melatonin on the gut, including its ability to modulate the composition and abundance of the gut bacterial population. Melatonin has direct influence over the microbiota and its antioxidant, immune modulating, and circadian regulating properties. This image is from a review article of clinical trials that summarizes the effects of supplemental melatonin both in the gut, below the blue line, and in the periphery, above the line. So in the gut, melatonin is going to help to increase tight junctions, reduce oxidative stress, modulate cytokines to decrease inflammation, and encourage microbiota, such as Akkermansia and Lactobacillus. And in the periphery, it's going to modulate cytokines, stress hormones, and glucose homeostasis. Drilling deeper to melatonin's effect on the gut, we're looking at a close-up representation of melatonin's effects on an enterochromaffin cell. We talked about is located in the epithelial layer in both the small and the large intestine. So that's the enterochromaffin cell here. It plays a really important role in motility and gut, and also important role in tryptophan, serotonin, melatonin production. So on the right, you see in the absence of melatonin, how insults such as heavy metals, poor blood flow, and NSAIDs are going to contribute to reactive oxygen species production, which is going to lead to membrane damage, apoptosis, and cell death, preventing the production of serotonin and ultimately melatonin in the gut. Whereas on the left, you see that the presence of abundant melatonin, both systemic and paracrine, can prevent, and this is melatonin here, preventing these red lines, that cascade of reactive oxygen species damage, which enables tryptophan production, which can convert into serotonin and melatonin, which has a paracrine effect in hepatic circulation to help to support detoxification. When we're talking about the serotonin-melatonin pathway, it's important to understand the kynurenine pathway, which is involved in the metabolism of dietary-derived tryptophan degradation. Only 5% of dietary tryptophan is metabolized by the serotonin pathway, whereas 95% is metabolized by this kynurenine pathway, which is essential for converting tryptophan to the neuroprotective kynurenic acid, and also nicotinamide, NAD+, for cellular energy. But when there's an excess of inflammation and stress, indolamines are activated, or IDOs, and they hijack this system and create a throughput away from serotonin and toward kynurenine, which is neurotoxic. And then the pathway stops there, and it interferes with the production of NAD+ and ultimately of ATP. Also, insufficient levels of melatonin have been shown to upregulate the kynurenine pathway. Elevated kynurenine is associated with depression, fibromyalgia, and chronic fatigue syndrome. Interestingly, exercise is one of the things that's shown to push metabolism away from the kynurenine pathway and toward the serotonin melatonin pathway. Low melatonin, specifically due to insufficient nighttime light, is associated with some specific mental emotional disorders, such as major depressive disorder, schizophrenia, and bipolar syndrome. As mentioned, low melatonin can increase the inflammatory cytokines that direct tryptophan down that kynurenine pathway, and that's associated with depression. Now that we've established some of the properties of melatonin, let's see how melatonin can benefit women's health. This is a really interesting narrative review that summarizes the literature around melatonin's use in reproductive pathophysiology and its potential use in assisted reproduction techniques to improve fertility outcomes. With the current data that we now have available, the authors concluded that both animal research and clinical trials provide evidence that melatonin supplementation supports increased fertility success by aiding in reducing oxidative stress. Note that 19% of couples currently in 2024 are experiencing infertility, and these levels are rising each year. There's an increased risk of oxidative stress associated with the assisted reproductive techniques coming from multiple sources. So in this image, what you're seeing is how all of the aspects of assisted reproduction are going to be impacted by reactive oxygen species. And the blue arrows are representing how melatonin has been shown to counteract those that pro-oxidation and provide antioxidation. So in the culture media, in the spermatozoa, in the oocyte, in the pre-implantation embryo, and also in the cryopreservation, melatonin has been shown to have antioxidant effects. There's quite a lot of research on melatonin and fertility out there in general. And it has been shown consistently to improve egg quality and increase pregnancy rates with in vitro fertilization by 50% versus cycles that don't include melatonin. And in women who had previous IVF failure, a cocktail of 3 milligrams of melatonin plus 4 milligrams of myo-inositol for 3 months improved oocyte quality and fertilization rate. So keep in mind, because everybody's always very concerned about, obviously, pregnancy and if melatonin is safe to take, no maternal, embryo, or fetal toxic effects have been reported with melatonin use. And rat studies have found no lethal dose of melatonin, even with extremely high doses of 800 milligrams per kilogram. During pregnancy, maternal melatonin plasma levels are elevated and they reach a maximum at term, but then they're going to return to basal levels after birth. These high plasma levels during late pregnancy are thought to contribute to fetal neuroprotection as well as to get their own circadian rhythm going. Breast milk contains melatonin and it reflects the diurnal rhythm with low levels during the day and high levels at night. Breastfed babies have been shown to have longer sleep times than formula-fed babies, which is likely attributable to the fact that melatonin is not in formula. So it's suggested that mothers should always nurse in the dark at night and not under a light to make sure that that when they're nursing, that there is plenty of melatonin in the milk, because the light is going to suppress that melatonin. And as well, when they pump milk, that they should differentiate which milk was pumped at night and which milk was pumped during the day, and to supplement the baby appropriately so that they get melatonin at night. PCOS affects polycystic ovarian syndrome, affects 8 to 13% of women. It's the most common endocrinopathy affecting reproductive age women, and it is the main cause of infertility in women. It's a very complex pathophysiology that involves many different factors and etiologies and pathways. Some of the signs and symptoms that you are probably familiar with are increased androgens, hirsutism, acne, insulin resistance, central obesity, amenorrhea, oligomenorrhea, poor sleep, anovulation, decreased fertility, increased cortisol levels, and increased anxiety and depression. And also, they tend to have altered melatonin levels, usually running lower. As well, an altered circadian pattern is commonly seen in PCOS patients, including poor sleep, increased cortisol levels versus controls, and lower melatonin levels. A later melatonin offset in the morning is also common, meaning melatonin is going to last longer in the morning, making it harder to wake up. And that late offset is also associated with increased free testosterone and insulin insensitivity. There are 2 melatonin receptor polymorphisms at the 1A and 1B site that are significantly associated with PCOS. Women with PCOS have a lower weekend sleep efficiency, meaning that when their stress is off, meaning that external stress is off, they aren't able to sleep in or make up sleep on the weekends, or they tend not to. So suggesting that that stress response continues even when there is not, even when the stressors are not present. These are 3 small studies involving small groups of women, 50 to 85 women, with some really interesting findings. The first one is showing us that with 6 months of 2 milligram supplementation of melatonin, there was improvement of or decrease of free testosterone, LDL were decreased, as well as an increase in FSH, and menstrual irregularities were decreased in 95% of these women. So they were able to regain a more normal physiological menstrual cycle There were no changes in lipid parameters and glucoinsulinic measures in this study. In the second study here of 8 weeks with 6 milligrams of melatonin, melatonin alone was found to improve sleep and HDL levels. And then when 250 milligrams of magnesium oxide were added to the melatonin, there was a significant decrease in insulin levels, cholesterol, LDL, and testosterone levels. And then when 10 milligrams were used over a 12-week period, there was improved mental health, improved subjective sleep quality, and a decrease in insulin resistance and total, and a decrease in insulin resistance and total and LDL cholesterol. This shouldn't say increase, it should say improved insulin resistance, total, and LDL cholesterol. And in women with PCOS undergoing fertility treatments, 3 milligrams of melatonin was found to improve in intrauterine insemination, was found to improve follicle size, increase endometrial thickness, and improve pregnancy rates. And with IVF, the 3 milligrams of melatonin plus 400 milligrams of myo-inositol was found to increase the number of mature oocytes and grade 1 embryos. So this is due specifically to melatonin's direct impact on the follicle. Our mixed results in some small studies of women with endometriosis and menstrual pain. In the first study, we're looking at endometriosis patients with 10 milligrams of nightly continuous melatonin for 2 months, starting on day 1 of their menses. There was a 40% reduction in daily pain scores and a 38% reduction in dysmenorrhea, as well as improved sleep quality and reduced use of analgesic and pain meds by 80%. In the second study, taking 10 milligrams on days 1 to 7 of their menstrual week for 3 months did not help their pain, but there were no adverse events. And in the third study, also in dysmenorrhea without endometriosis diagnosis, 3 milligrams during the menstrual period only reduced pain and enhanced subjective sleep. So I think that I really like this slide because it gives us some examples of continuous use of melatonin in this first study versus melatonin only being used during the menstrual week. And there was one study with 3 milligrams during the menstrual week, which did show reduced pain. With a higher dosage during the menstrual week, it did not have that effect, whereas a higher dosage that was used on a regular basis did have so many positive benefits. So we'll be talking about this a little bit later in the dosing section, but I just wanted to point that out, that there is so much variation in the research in terms of dosing and whether dosing is consistent or just during certain time frames. I will say that in my practice, women with endometriosis and dysmenorrhea, I do give them usually 3 milligrams of melatonin continuously throughout their cycle, and I have had it to have an impact on pain during menses. In general, women have a higher insomnia rate than men. And anybody who works with peri and postmenopausal women know what a significant impact this stage of life can have on sleep. I was surprised to learn that there's a higher percentage of perimenopausal women, 56%, that sleep less than 7 hours per night, as opposed to menopausal women, 40% sleep less than 7 hours per night. Well, neither of those are acceptable and are very chilling statistics. So I just wanted to point that out to you, that this population can really benefit from melatonin supplementation. So knowing what we know about melatonin decreasing with age, it would follow that there is a weakened circadian signal as a result. So here you're looking at daytime napping on the left in white, this white section, and nighttime sleep in the shaded area on the right. And then you'll see that women aged 20 to 30 with a regular menstrual cycle are the blue line in these 3 different examples, and postmenopausal women are the red line. You can see that postmenopausal women have more arousal in both daytime and nighttime sleep, more mid-sleep alertness at night, and a lower melatonin amplitude at night than younger cycling women. When it comes to estrogen, there's some conflicting data on whether there is a specific relationship between estrogen and melatonin. There aren't a lot of studies. Conjugated equine estrogen has been found to reduce melatonin secretion in both peri and postmenopausal women, but there's been no statistical significance shown between estradiol levels of melatonin beyond that expected age-related decline of both of them. In vitro melatonin has been shown to reduce estradiol levels in breast cancer cells, and it's been shown to improve sleep, mood, and vasomotor dysfunction in postmenopausal women. There's been one single case study where a woman on melatonin therapy had prolonged estrogen levels after later in her life when we would have expected them to drop, and it delayed the endocrine changes in FSH and LH, and also delayed her menopause. But there have been no other studies that have reproduced this finding. Two systemic reviews and a clinical study on melatonin in peri and post menopause have shown that in addition to improving sleep and climacteric symptoms, melatonin was shown to improve depression, anxiety, bone density, lean. It was a huge review study, so the dosages were all over the place. And as I mentioned, I usually start at 3 milligrams in all of my women who are experiencing sleep difficulty, and I increase as needed until their sleep is organized for about 3 months, and then I drop down to a much lower dosage, trying to shoot for that 0.3 milligrams, which is what the pineal gland is about what the pineal gland is going to be producing in a 24-hour period. So remember that 0.3 milligrams is approximately 0.3 to 0.5 milligrams of what the pineal gland is going to be producing, how much melatonin it's going to produce in a 24-hour period. So the pineal gland is the organ with the highest rate of calcification in the body. So in these images that you can see pineal calcification starting in a 14-year-old, here in a 47-year-old, and here in a 62-year-old, and just comparing these images to osteons of bone. So you can just see how dense that calcification can become. I recently had a chiropractor tell me when I was on the phone with them at Dr. Jada that she was able to see calcification in her patient's pineal gland as an incidental finding on an X-ray. So this is real. And she was shocked because she didn't even know that pineal calcification was something that happened to people. And so she did her research, and she realized that it was an actual phenomenon. She happened to call me shortly thereafter. We had a conversation about it. So the question is, where does that calcification come from, and why does that calcification happen with age? So this original paper was in 2018. There was a lot of postulating and a lot of guessing, but not a lot of answers. And there is a more recent review paper that was done in just in 2023, and found that pineal gland calcification was significantly associated with age, sex, male mostly, low altitude, low sunlight exposure, ethnicity, white, artificial light, cell phones, fluoride intake, poor nutrition, and neurodegenerative diseases. And the researchers concluded that a modern lifestyle that involves the use of electromagnetic frequency technology, such as cell phones, that was playing a role, as well as using fluoride in mouthwash, toothpaste, and tap water, and herbicides, that they were playing a critical role in this calcification process. And also postulating that melatonin, being such a potent anti-inflammatory and antioxidant, could potentially play a role in reversing that calcification. Again, we don't have any long-term studies on this or any specific studies on this, but knowing what we know about the properties of melatonin, we could make that leap that it could potentially play a role in improving that calcification. Women make up 2/3 of all Alzheimer's patients over the age of 65, suggesting that it's almost twice as common in women than men. So in Alzheimer's, pineal dysfunction is associated with reduced neurogenesis in the hippocampus and the hypothalamus, and reduced melatonin production is associated with sleep disturbances, sleep disturbances, sleep irregularity, and poor quality sleep that we see in Alzheimer's. So that reduced melatonin production seems to be related to what we're seeing in Alzheimer's. And there seems to be a link between irregular sleep patterns and a risk for dementia in general. Those with irregular sleep patterns have been shown to have 53% more likelihood of developing dementia in a UK study of 88,000 participants. So another reason to get patients' sleep organized. Those with Alzheimer's, melatonin has been shown to improve sleep and sundowning, and that is what happens when symptoms worsen around and after the time that the sun goes down. So in those with only mild cognitive deficit, melatonin has been shown to improve the ability to remember previously learned information, and it improved depression. Light has been shown to be a proven therapeutic intervention in both sleep and in circadian disturbances in Alzheimer's patients. The jury is still out if light can impact cognition and behavior, but there's this developing theory that altered retinal function may be a primary contributor to the altered circadian rhythm in dementia, as those amyloid tau proteins are detectable in the retina of Alzheimer's patients. There's also a breakdown in the retinal barrier, which makes them more sensitive to light and less able to tolerate sometimes bright natural light, which could influence that pathological progression. So they stay out of bright natural light because of their sensitivity when they really need to have that exposure to bright natural light. So even if their eyes are closed and they're sitting outside, they're going to benefit from that light. Image depicts parallel inflammatory mechanisms both in the brain above the dotted line and in the periphery below the dotted line that are going to lead to the insulin resistance and glucose intolerance that we're going to see in Alzheimer's. So you can see that there's a connection between increased brain reactive oxygen species and inflammatory cytokines that contribute to insulin resistance, mitochondrial dysfunction, and decreased melatonin levels. And below the line in the periphery, you can see how adipose tissue is associated with type 2 diabetes and that they produce the same inflammatory cytokines that can cross the blood-brain barrier that are also produced in the brain. And these cytokines are going to interfere with the circadian rhythmicity of the pancreas, which is mediated by melatonin receptors. So in rats with melatonin deficiency, they were found to have leptin resistance and they had increased body weight, and it was reversed when they added back in supplementation, melatonin supplementation. As well, melatonin restored insulin secretion and signaling, improved mitochondrial function, and reversed receptor resistance in those rats. So this image bears to light the mechanisms that are involved in why Alzheimer is now being called diabetes of the brain, or type 3 diabetes. And it's a good reminder that Alzheimer's incidence is higher in obesity and type 2 diabetes. So this is a really interesting slide, and I'm going to do my best to explain it to you because I think it's really important to understand. There is kind of an ongoing conversation over whether or not melatonin supplementation is going to benefit or interfere with glucose metabolism. This is a recent small study in diabetic men that shows reduced insulin sensitivity after a 10 milligram dose of melatonin, which may be related to a polymorphism in the melatonin receptor MTNR1B, which is often found in diabetics. Normally, melatonin levels, so what we're looking at here is that solid gray line, melatonin levels, this is in controls, is going to decline after the first few hours after awakening, and it's slowly going to increase in the last hours prior to sleep, creating 2 windows of risk if one eats during those times, okay? So this is affecting everybody. We really should not be eating while we still have melatonin coursing, through our system. However, even more so if one has the MTNR1B receptor variant, as many women with PCOS do. And you can see that that's represented here by this dotted line. So this is when this variant is present, you can see that melatonin is still in full effect in the morning until much later than someone who does not have that variant. And as well at night, you can see that that melatonin is perhaps going to rise a little bit sooner. That DLMO might happen a little bit sooner, and it's going to be much more amplified than it is going to be in control. So if melatonin is given to this population, it's important to monitor their hemoglobin A1C and also really keep an eye on when they're eating vis-a-vis this graph. And it's a great argument potentially for intermittent fasting or time-restricted eating to ensure that somebody is not consuming food when it's potentially going to be interfered with by melatonin and decreasing its ability to have, and decreasing blood sugar balance. Oh, and I also wanted to mention that this MTNR1B variant is more commonly found in certain populations, specifically those of European, Asian, Native, and Native American ancestry are at higher risk. And the MTNR1B variant is also found in women with PCOS. Melatonin supplement. So this is just in terms of just a quick survey of cardiovascular effects, because I didn't want to spend a lot of time on that in this presentation. There's a lot of information out there. But I wanted to just point out this huge systematic review from 2022 of cardiovascular effects in human and animal subjects. It was found that melatonin supplementation regulated heart rate, reduced nocturnal blood pressure in patients with hypertension, and was found to diminish the risk of developing reperfusion injury after myocardial infarction. As well, some of the things that we're already familiar with in terms of reducing oxidative stress and regulating production of cytokines, modulating metabolic activity, and preventing apoptosis. Melatonin has a surprisingly important role in bone health. This was new to me when I was doing my research for this presentation. This is another huge review study where there was oral administration anywhere between 1 and 10 milligrams and a local administration of 1% ora-based cream topically to gum tissue for periodontitis. Treatments were between 1 and 2 months, and there was also a 6-month study. I urge you to take a closer look at this slide on your own time, because it is an entire presentation in itself, and truly remarkable the effects that melatonin has on bone. But I wanted to just point out a couple of the major findings from this huge research study. One where melatonin was shown to restore balance of bone metabolism. And I wanted to just point out the decrease in autophagy of osteoblasts, as well as been shown to improve fracture healing, promote periodontal healing, and restore balance of cartilage metabolism. And you can see in all of these examples, decreasing inflammatory factors, increasing antioxidation, decreasing inflammasomes, and cytokines are all playing an important role in this process. So again, take a look at this and get to know this a little bit better, because it's just fascinating research. Melatonin is used as an oncostatic agent. It should be prescribed during the day, because that's when tumors are undergoing aerobic glycolysis, and that is called the Warburg effect. And it's a term for an increased rate of glucose uptake and inflammatory functioning of cells during daytime. It can be given with other chemotherapies, as it hasn't been shown to interfere with cancer effects, and it can help to limit collateral toxicity of chemotherapy. So using melatonin with chemotherapy has been shown to potentiate the chemotherapeutic properties and even reverse intolerance to these medications. So you'll often find that melatonin is added to cancer treatment protocols. Let's look at some of our testing options where we can get take a look at circadian rhythm. So this specifically is saliva testing of melatonin. And you can see here that the green zone is the optimal melatonin curve during the day. So we're looking at melatonin during the day. And you can see, as we were looking at some of those other slides, that we're going to expect melatonin to be decreasing in the morning. And then this is morning, evening, and night. And you're seeing melatonin is starting its ascent, following that green curve at dim light melatonin onset. So here on the left, you're seeing what may be some evening light suppression with this level of melatonin not rising as it should, probably something that we're likely to see in somebody using their their devices at night, watching television, being on a computer, etc., because that LED-backed blue light is very suppressive to melatonin. And on the right, we're looking at a phase delay, meaning that in the morning, melatonin levels are quite high, and they're not quite increasing in the evening. So this very well may be an adolescent, right? Because they go to bed so late. So we're not really seeing much activity with their melatonin level here because they tend to go to bed so late. And in the morning, they've still got a lot of melatonin, making it difficult for them to wake up. And here we're looking at a cortisol report where somebody added on a single point melatonin. And this would be just the night, just this melatonin is just from right before going to bed. And in this particular patient, we're looking at low melatonin levels, which isn't surprising given the fact that this patient also has some cortisol levels that are creeping up at night. So we know that cortisol is going to suppress more melatonin. We know that cortisol levels could increase, again, with that blue light, LED-backed screens, etc. Screens, television, computers, gaming, stress, etc., and it's going to suppress those evening melatonin levels. And then I just want to show you, I just find this research fascinating that's showing you that even after one night of partial sleep deprivation, cortisol levels are 37% higher the following evening. And so this is very similar kind of thing that you're going to see with jet lag. So you've been awake on an airplane all night, you stay awake all day, you finally are ready to go to bed at your new location, but you can't fall asleep. So another indication for melatonin to give that signal to the brain that yes, in fact, it is time to go to sleep. And this is an example of our neurotransmitter testing, our urinary neurotransmitter testing. And I wanted to point this out. This particular result is showing us some low range serotonin. So anytime we're seeing that low range serotonin, we need to be thinking that this person may need some melatonin, that they're likely not converting it the way that they need to be. So I wanted to show you, again, our neurotransmitter. I want to show you our neurotransmitter path chart. I showed it to you really briefly before when we were talking about that serotonin pathway, but I wanted specifically to point out what some of those nutrient cofactors are that are going to be supporting this pathway. So P5P, the activated form of B6, iron, BH4, which is produced endogenously, and it's supported with CME, the methyl donor, B3, vitamin C, molybdenum, and zinc, all crucially important for tryptophan to be able to convert into 5-HTP. And in order for 5-HTP to convert it to serotonin, P5P, the activated form of B6, and then CME in order for melatonin to be produced. And I point this out as well because not everybody wants to take melatonin or they've had an adverse response to melatonin. And so I really encourage your familiarization with this pathway. I threw exercise in down here because of what we were talking about with kynurenine. 400 milligrams of magnesium oxide has been shown to improve melatonin levels, sleep onset latency, waking too early, sleep duration, vasovagal tone, and improved stress reduction. 250 milligrams has been shown to improve depression within 2 weeks, regardless of baseline severity, age, and gender. The form that I usually recommend for sleep, because it absorbs so well, is glycinate, and always citrate for when one has a tendency for constipation. So I wanted to show you this because of the last slide where we were looking at the importance of magnesium in this cascade. And also B6, as I mentioned several times, deficiency can contribute to insomnia. It's a cofactor in the production of serotonin, melatonin, and GABA, which is an inhibitory neurotransmitter. Higher B6 intake has correlated with a lower risk of depression, and it supports HPA active health. Let's just talk about some of our treatment considerations in terms of supplementation. But first of all, I want you to think about going all the way back to the beginning of this presentation. We were talking about light and dark. So what is your patient's cumulative melatonin deficit related to light at night, or how well they've been sleeping at night. If they have a lifelong history of sleep difficulty, this might make them a very good candidate for melatonin supplementation to try to bridge that antioxidant, anti-inflammatory deficit gap. And unless one has exposure to regular nighttime darkness with minimal light pollution, they are a likely candidate for supplementation. I'm also a really big fan of sleep masks, and there are some that you can get that have cups that can Velcro in and out of a strap that goes around your head so that you can adjust it to the width of your eyes and the shape of your eyes to get it in, like form a seal around your eyes for sleep. So I encourage you to take a look at all the different options that are out there to ensure that one is not noticing light coming in through that mask, because if so, then the mask really isn't doing the job. So what about daytime light exposure? This is a really interesting research study that was done in Seattle on 500 university students. And I love to point this out because, as we all know, Seattle is not a sunny place. It tends to be a cloudy, rainy, gray place. But they found that every hour of daytime outdoors was shown to advance bedtime by 30 minutes. Conversely, each hour of post-dusk artificial light from lamps and screens was shown to delay the rhythm by 15 minutes. However, they found that daytime outdoor light exposure, even on a cloudy day, was a more powerful signal than evening light exposure, and it could counterbalance the effects of evening light exposure. So I will often get questions about windows. Will a window give you that direct daytime light to suppress melatonin levels and to encourage cortisol and to, give that signal to the suprachiasmatic nucleus of that circadian rhythm? And unfortunately, no, it's not going to have the same impact. It could have some benefits, especially with the most amount of light that one would be experiencing with a southern facing window, and without tint, without blinds, and without trees getting in the way. There could be some benefits, but generally speaking, the window itself is going to have attenuating effects on that light's impact to the suprachiasmatic nucleus. A full spectrum light box, for those who can't access natural daylight and or for shift workers, 20 to 40 minutes first thing in the morning, can have that same effect as daylight, and it can be used throughout the day to stimulate that signal of daylight in people who aren't able to get outside and get that natural light exposure. And then there's also some great research on camping outdoors for one night with no artificial lighting other than a campfire, and that's been shown to completely reset the circadian clock. Just one night of that pitch darkness with no light. We've all heard our patients say that had a bad experience with over-the-counter synthetic melatonin. Why does that happen? Well, while melatonin is generally considered safe, it's not FDA regulated, and there is a small degree of risk if you're taking over-the-counter supplements because they are often chemically synthesized, and there's often a lack of quality control, which enables many potential contaminant ingredients to show up in the supplements. This is from a Canadian study of 31 grocery stores and drugstores over-the-counter melatonin products, and they found that the label claims did not match up with the actual dosages within a 10% margin in over 70% of the supplements that they tested, meaning that one could think that they're taking 5 milligrams of melatonin, but they're actually getting 50 milligrams, or maybe they're only getting 0.1 milligram. Whereas if you're using a physician grade or a professional grade product, it's a much better choice because that means that there is third-party testing that's going to ensure that the dosage claim on the label matches what's actually in the product. And as well, I wanted to point out that can be a lot of negative side effects associated with these potential contaminants that one can be reacting to, which they're mistaking it to be a reaction to melatonin, but it could be the ingredients, or it could be that they're getting a very, very high dose that they're unaware of. So I want to put a plug in here for phytomelatonin from plants. There are supplements that do contain phytomelatonin. It acts as a natural sustained release because it needs to be converted to melatonin. So in the case of phytomelatonin, its natural origin is going to rule out all that contamination from the chemical synthesis process. These graphs that you're seeing here represent the ORAC value, which is the antioxidant capacity of plant-derived melatonin. That's the blue bars versus synthetic melatonin, the gray bars. And in this case, the plant-derived melatonin came from alfalfa, rice, and chlorella. And while some foods are rich in phytomelatonin, it's really best to think of them as an antioxidant source as opposed to a melatonin source. You would have to, in order to get the 0.3 milligrams that's naturally produced by the pineal gland in a 24-hour period, one would need to eat 50 pounds of fresh cherries or 857 cups of walnuts or 11 Fuji apples. You get the picture. I know a lot of people really love their tart cherry juice and they really have great benefits from it. And if so, that's fine. My concern always is blood sugar. So maybe it's helping you fall asleep, but is it going to wake you up in the middle of the night when your blood sugar crashes after all of the sugar that's in that product? So generally speaking, I like to keep food away from bedtime in order to prevent any kind of blood sugar crashing in the middle of the night. Although some people, in order to prevent that blood sugar crashing, need to have a little bit of protein at bedtime. That's another conversation for another time, but I just want to put that out there. Again, there's going to be so much variability for each person. So let's talk about dosing. So why do we say lowest dose for the shortest duration? Well, we just don't have long-term research specifically on high dosages of melatonin from a safety perspective, right? So we do have some longer-term studies, but they've never been looking at safety. They've only been looking at sleep. So we're extrapolating from that research to come up with this information. So there's two forms of melatonin. There's immediate release and there's sustained release. Immediate release for somebody who is having a hard time falling asleep, usually taking it anywhere between 30 minutes and 2 hours before bedtime, depending on your patient. If you need to incrementally move up someone's bedtime, I'll incrementally move up that dosing, that immediate release dosing by 15 minutes. And then there's a sustained release to prevent that middle of the night waking. It's going to have a 3 to 6 hour slow release over time. Remember, melatonin has a very short half-life. It's only 45 to 60 minutes. And so it's not going to be present in the system for very long, especially at those lower dosages. Lower dosages have been found to be as or more effective than higher dosages, but you may use a higher dosage in a woman who is having hot flashes, for example, because the higher the dose is going to have greater temperature lowering benefits. And that therapeutic response is not necessarily immediate. So be patient. If someone said, yeah, I used melatonin for a couple of weeks, it didn't help my sleep, it may not have been enough time. 64% of subjects have been shown to have an immediate response, but it could take as long as 8 weeks for one to experience the effects of melatonin. So I included this graph because I wanted to show you some of the differences between how the sustained release versus the immediate release might work. So here in the red, we're looking at how that immediate release works. Some people, because of this really intense spike, are going to experience a kind of an offset of sleep here. So they might wake up a little bit when that melatonin level goes very low. I will give a sublingual form before bed. And I find that I don't have the same problem where the kind of this melatonin crash that might cause an awakening. Here you're getting an idea of what that slow release melatonin looks like. Here the yellow over time. And this blue here is giving you example of, or sorry, this black line here is giving you example of what our normal melatonin release is going to look like over time. And that this is specifically was some kind of a marketing device for selling a product that is a combination of immediate release and sustained release. I don't know what the product was, but they were trying to show you that that combination is going to help to bridge these two gaps and bring it together and have a nice release over time, both to help you fall asleep and to stay asleep. So I will often give patients both a fast release and a sustained release. The fast release is usually going to be in a spray form or a sublingual form, so they're going to have immediate effects. So to address the question, what is the best dosage of melatonin? This is a summary of 187 references of melatonin dosing in the research for lots of different purposes, and that you can see that the doses are all over the place, from 0.5 milligrams all the way up to 20 milligrams. Again, to point out that those higher dosages are going to have greater temperature lowering effects. This slide was kindly loaned to us by Dr. Kim Ross, who's one of the authors of the Is Melatonin the Next Vitamin D paper. And she combed through a lot of research to show dosages of melatonin used to successfully support sleep in various conditions. And I bring this to your attention again to point out that large variation in dosages, anywhere from 1 to 50 milligrams, depending on condition. And these are her references for that slide. And then again, does melatonin have side effects? Well, only a small percentage of people seem to respond to melatonin in a negative way, but we all have had those patients. And what are those side effects they might get? Well, they might see some fogginess, grogginess, daytime sleepiness, dizziness, mild headache. Maybe they'll wake up in the middle of the night for urinating, maybe some nausea, mild diarrhea, or vivid dreams, usually related to those higher dosages. So try them at a lower dose, a 0.3 milligram, and try an herbal melatonin product to see if they can avoid that. And so again, I just wanted to mention that no studies have indicated any serious adverse effects compared to placebo, and that controlled studies have indicated long-term administration only induces these mild effects compared to placebo. And here's some more corroboration of the safety margin. This chart outlining studies with doses as high as 1,600 milligrams. And I think I mentioned earlier that in animals, melatonin has never been fatal when given orally or subcutaneously. Hence, the LD50, which is considered the lethal dose, has been stated to infinity. So there is no legal dose of melatonin. The commonly held misperception that melatonin is going to suppress endogenous production. It's all over the internet, and I've answered this question so many times, and the answer just simply is no. No suppression of endogenous production has been shown in the research. Remember, it has a very short half-life, so there isn't any feedback as well. There may be a little bit of temporary receptor saturation at high doses, but that going higher with dosaging may not improve symptoms. So sometimes going lower with dosages can improve symptoms. So that's really the only thing that we might be able to come up with in the research related to this question. But the answer is no, it does not improve. It does not impact endogenous production. Anytime that you're considering putting your patient on melatonin, it's important to first check if there are any drug interactions. I had a patient just the other day who was on an SSRI, and her melatonin, when she included melatonin in her treatment protocol, she felt groggy and tired all day long. So we had to pull it out, and then we'll go back and try her with a lower dose. So we've covered all of the factors that could decrease melatonin production. I just wanted to end on the note of just talking about alcohol briefly. While alcohol is a somnogen and it helps one to fall asleep, it greatly interferes with that second half of sleep because it takes 4 to 6 hours for the liver to metabolize alcohol. And at the end of that process, usually in the middle of sleep, there's a little bit of an increase of cortisol, and that can manifest in an increased heart rate. It could manifest in some urination or the feeling of being wide awake, and it can make it difficult to fall back to sleep. It can take hours or minutes. So whenever my patients are complaining of waking up in the middle of the night and getting back to sleep, I always ask if there's alcohol in the picture, and I urge them to go off of it for a little while to see if that helps their middle of the night waking, or to use it earlier in the day so that 4 to 6 hour liver processing period is complete by the time that they go to bed. So thank you for listening. I hope that this has given you some food for thought around using melatonin in your clinical practice with women. And hopefully it's taken some of that mystery and stigma out of some of those rumors that we hear online and giving you the confidence to use it in your practice. So I'm happy to take some questions now. This is my little dog, Olive, in the winter with her coat on, getting lots of natural sunlight to help set her circadian rhythm.